Good morning, good afternoon, good evening, depending on where you're connecting from. My name is Lucy Kiarie, an immunization advocate and a member of the Boost community. I'm going to be your moderator for today's session on vaccine misinformation, control and prevention. Globally, vaccines and vaccination have long attracted skepticism and generated conspiracy theories, and continue to do so more rapidly in the new information age of digital communication and social media. Various factors have undermined confidence in or contributed to complacency about vaccination, including the circulation of false information about vaccines, even though the extent to which misinformation contributes to a decline in vaccination is not always clear. While the information may be fake, the consequence of misinformation is real and poses a serious threat to public health. The introduction of HPV vaccine in Kenya in October 2019, for example, was met with myths and misconceptions, which overall contributed to a slow acceptance and uptake of the HPV vaccine, as some parents took a wait-and-see attitude. This example presents just one of the many challenges that immunization professionals, including many members of the Boost community, grapple with, and therefore calls for knowledge to expand our understanding of the problem, as well as identify tools in order to develop contextualized solutions to address it. This webinar on vaccine misinformation, control and prevention is part 1 of 3 webinar series. Sabin Vaccine Institute and UNICEF are collaborating on information sharing and learning effort to broaden understanding of the impact of misinformation on vaccine acceptance and hesitancy, and to better equip immunization professionals to manage this impact. Upcoming webinar topics will be on infodemiology in practice and inoculation against disinformation. We'll provide more information on these sessions later in this presentation, and also in our follow-up to attendees. We also hope that if you've not joined, if you haven't joined Boost community already, you sign up and join the ongoing conversations with other immunization professionals. I would also like to tell you that we are tweeting. Follow Sabin on Twitter at Sabin Vaccine, and tag Sabin when you tweet. Thank you. Next slide, please. So we have a few instructions. Mute yourself to limit the background noise and feedback. Also, raise your hand during the discussion to speak. The raise hand button is below your screen. Also, ensure that you submit your questions throughout the webinar using the Q&A question located at the bottom of your screen as well. You can also respond to questions and engage through the chat at the bottom of your screen. Use the chat button to introduce yourself in the chat. Continue introducing yourself. I'm monitoring the chats. So without further ado, we have 3 panelists with us today. We have Aisha Durrani, Communication for Development Specialist, Health Section in the UNICEF Pakistan Country Office. In addition, we also have Jonathan Shadid, the Chief Communication for Development, UNICEF Pakistan Country Office. Last but not least, we have Angus Thompson, a Senior Social Scientist, Demand for Immunization, UNICEF. So we are going to launch a poll question. It's going to appear on your screen. So the poll question is, what do we mean by misinformation? We have around 30 seconds to answer this. What do we mean by misinformation? We have around 30 seconds. As we answer the question, let's remember to use the chat box to introduce ourselves. Thank you. So around 25% say that intentionally false and misleading information. And we have 68% saying that information that is false, but not necessarily intentionally false. Then we have 8% of us saying false rumors. So the correct answer is B. Misinformation is information that is false, but not necessarily not necessarily intentionally false. So Angus is going to talk through what we mean by misinformation and disinformation pertaining to vaccines, some strategies his team is developing to debunk and manage misinformation, and soon some resources that will be shared by UNICEF. Angus is going to share his screen. So if you have a question, kindly use the Q&A button to share your question, and we are going to respond to the questions as they come. Thank you. Angus, take it away.
Thank you so much. Hi, everybody. Thank you all so much for joining us today from all around the world, it seems. What I'd like to do is take you on a little trip through what we know about the evidence, what the evidence tells us about misinformation, disinformation, and its potential impact on people's vaccine-related decisions. And then look at what it is that we know so far that might help us tackle this. So we have solutions, we have potential tools out there, and we hear a lot about this problem and perhaps a little less about what it is that we can do about it. So bear with me, I want to give you a little bit of background. I've got you for about 20-25 minutes on this part of the flight. I'll move reasonably quickly, but try to keep things clear. And I'm actually going to come back to that question that we had about the definition of misinformation in a second. But this is not news to anyone, I guess. We really have had this parallel so-called infodemic with the COVID-19 epidemic or pandemic now. So this is, as Tedros noted, we're not just fighting the epidemic, we're fighting the infodemic. And fake news spreads faster and more easily than the virus. And it's just as dangerous. And these are very true words, and I'll show you why they're true in a minute. Two numbers. Early on in the pandemic, our UNICEF's partners, public good projects in their Project Vector detected a doubling of vaccine critical messages within the first months of the pandemic. Those messages being viewed over 4 billion times. Another study, and this is just a sample, identified a small but very, very effective network of anti-vax profiteers, people who are profiting from anti-vaccine disinformation, who managed within the pandemic to increase their followers by 1 million people. And this is a $1 billion industry, or that's what the Center for Countering Digital Hate estimated. So the pandemic has certainly been having an impact on vaccination. Indeed, vaccines, immunization has been sucked into this perfect storm of disinformation. I'm not going to go in this in detail, but as early as March, we were detecting a rumor that would turn out to have real traction throughout the Francophone world, was additionally fueled by comments coming out of France, and is still circulating and mutating, taking on new forms, but has a core theme, which is that COVID-19 vaccines are being tested on people in Africa without their knowledge. So as I move to the definitions, please, in the next couple of minutes, let us know in a few words what kind of misinformation or disinformation you might be encountering most frequently in your work. First of all, we're interested to know, are you encountering it? And secondly, if yes, what does it look like? And use the chat feature for that, please. So a few definitions. First of all, information. Those of us in behavior change understand that throwing information over the fence doesn't have any impact on people's behaviors. What changes our knowledge and eventually potentially our behaviors is information that is data with meaning, that is trusted, is actionable, and is sticky. It stays within our worldview, within the way we see the world. And I'll come back to what I mean by that. Misinformation, as most of us got, is unintentional falsehoods that are circulating out there. These can dilute, they can distract, they can distort. They can make it difficult for people to start to triangulate the truth, particularly in the social networks in which this circulates. But a very important distinction is disinformation. So these two words are very distinct in English. Disinformation is deliberately engineered falsehoods. It is weaponized misinformation. It is misinformation that is designed to deceive you, designed to stick within your beliefs, and designed to make you spread it, very much like a virus. It is falsehoods that are created and disseminated using deceitful tactics and with malicious intent. And this is important because what I'm telling you now is one of the keys to the way that we might be able to address disinformation. It in fact comes from, we think, the Russian word that was coined in the 1920s when the Kremlin set up a disinformation institute. And it is now being used, created and used quite widely, and obviously we'll get to social networks, but they are helping with the spread. But the question that any behavioral scientist should ask is, so what? Does it have any impact on people's perceptions or on their behaviors? And the answer is, at least in some people, yes. So I've been waiting for months to be able to use my word of the year, Hamsterkauf, which is a German word that is a combination of hamster and shopping and means hoarding behaviors, and which I've used often in my daily life. People who believed in one study that coronavirus was actually an engineered bioweapon were more likely to adopt hoarding behaviors. We've seen these super conspiracy theories. 50% of Americans who name Fox News as their primary news source believe Bill Gates is plotting a mass COVID-19 vaccination campaign to implant microchips in billions of people. These people said that they believe this. There are some methodological problems with some of these studies, but we know that there is a substantial proportion of people who at least say that they believe these things. And we know that anti-vaccine conspiracy beliefs may significantly correlate with people's intentions to vaccinate. So disinformation can have a very real impact on people's behaviors. It can be harmful in the real world, and it can impact people's vaccination decisions. So why is this? What's going on? I'm going to give you 2 or 3 key points to remember that are key to the success of misinformation. First of all, it's very sticky. It can stick within our minds, rely on corrected misinformation, even though they've been corrected in their reasoning, even if they've understood and believed and even able to remember the correction that they received. And there are a number of things going on that makes it sticky. I've given you a few examples here. Think to the last time that someone told you you were wrong. How did you feel? Nobody likes to be wrong. And the righting reflex when we tell someone they're wrong and try to correct them can significantly increase people's what we call psychological reactivity. It reduces their receptivity to what it is that we might want to say to them. Fear can backfire. Fear appeals are a double-edged sword and must be carefully used in measured doses. People confuse familiar with truth. Daniel Kahneman put it beautifully: a reliable way to make people believe falsehoods is frequent repetition, because familiarity is not easily distinguished from the truth. So we need to limit our repetition of myths. And what's important in particular with vaccination is that often when we try to correct people, it can be taken as a challenge to their very identity. In particular, if that misinformation is not resonant or doesn't fit within the worldview that they find themselves, doesn't fit with their beliefs. And so it's important for us to be thinking about how we can nest our corrections within the views, the beliefs of people that we're communicating with. 2 words on vaccination. I'm sure many of us on this call know this. It's a complex behavior, the decision to vaccinate. There is a continuum of vaccination decision-making, from a very small minority of people who refuse all vaccines, a larger group pending the context, who we call often hesitant. But this is a very diverse group, heterogeneous group. Some may just vaccinate even though they've got questions. Some may accept some vaccines but delay others. Some may refuse a vaccine but not others. We have what we call passive acceptance, where people will accept all but may not be sure about it. And what we're seeking to achieve is to generate at a community level active demand for vaccination. The second thing I'd like you to bear in mind about vaccines in terms of it being a complex behavior is that these are decisions that are sometimes, not always, that may sometimes have very deep roots. So they may be affected more superficially by our thoughts, our feelings, our attitudes, by cognitive biases, confirmation bias. I see what I believe rather than believing what I see. I reinforce my worldview. Trust, getting a bit more deep, is the bedrock of vaccine acceptance. Very, very important. I'll come back to this theme. Social norms, beliefs, and it can even go as deep as those moral values that we all share. And we have an increasing emerging evidence to show that there are specific moral values that correlate with people's decision making. The point here is that this is complex. This is a complex challenge, and therefore simple solutions will not work. So from vaccines to truth. Time published this in 2018, rather presciently. 2017, is truth dead? I think in an age where we see the president of the world's largest democracy spouting 17, on average, 17 falsehoods a day, we are definitely within what we might call a post-truth era. But this relates, in a sense, to the some of the psychology that I've touched upon, a situation in which people are more likely to accept an argument based on their emotions and their beliefs rather than one based on facts. We don't like to have our emotions, our beliefs, our values disrupted. And so one of the, a wise philosopher said this a long time ago, and I think it really holds true. You're going to find that many of the truths we cling to depend greatly on our own point of view. And I'll give people 10 seconds to guess who that philosopher was. Put your answer in the chat. There we go. There's another clue. We'll see if people got it at the end of the talk. Truth and trust are intertwined. We get our truths from people that we trust, from people that we find trustworthy. And for vaccination, this is doubly so, because of the fundamental role that trust plays in the decision-making process that many people go through around vaccines. When we say trustworthy, we're talking about an entity, a person, an organization that is credible, that is expert, but most importantly, is concerned about us, is empathetic. We trust the people who we think have our best interests in heart. And again, I'm giving us, in each of these slides, I'm giving us clues towards the solutions that we might be putting in place to disarm disinformation. Indeed, there's been a recent kind of a model proposed for belief in conspiracy theories that suggests that there is this double whammy of susceptibility to misinformation and mistrust. And I think what I've shown you so far indicates that vaccination, if this is the case, vaccination is particularly vulnerable to disinformation that is able to stick and that is able to undermine people's trust in the trusted messengers. A recent study found that, a very recent study only published a couple of weeks ago, found that scientists still hold a very, very important role. It was a multinational study, still carry an enormous amount of trust. We know for vaccination that healthcare professionals are always the most trusted voice, but very importantly, we know also that scientists are very trusted voices as well. Now, we've talked about how it sticks. How does it spread? I don't want to spend a lot of time on social platforms today, it's enough to understand the fundamental idea that they were predicated upon. This is a quote from the first president of Facebook. The thought process behind building Facebook was how to consume as much of your time and conscious attention as possible. A little dopamine hit every once in a while. Yep, when you're liked, when you share something, you get a little dopamine hit because someone liked or commented on a photo or post. It's a social validation feedback loop, dramatically exploiting a vulnerability in human psychology. Social platforms are addictive, they're attractive, they're irresistible, and they're all those things by design. Clickbait was designed. It incentivizes attention grabbing. It incentivizes outrage. And it was designed to leverage our deepest human instincts. And so this is a crucial point that we need to bear in mind as we think about how we can manage things. This was a really nice social network analysis done on Facebook, published a few months ago by Neil Johnson and colleagues. There are many key points, many interesting points in this. But the one I want to leave you with today is illustrates the first point that I want to leave you with in terms of what it is that we can do about this problem. This is a map of, so the nodes are people, the nodes are people or accounts, and the size of them reflect the number of followers. The lines reflect the interactions between those accounts. The blue dots are pro-vaccine pages, the red dots are anti-vaccine pages, and the green dots are the most important pages of all. They're the people, the accounts where people have not yet taken a position on vaccines. And this study showed very clearly that the anti-vaccine, the vaccine critical sites were effectively reaching out into those undecided pages and entering into those undecided groups, whereas the blue pro-vaccine accounts were by and large talking to themselves. And so the first point I'd like everybody to take away from this presentation is, if we don't take a strategic approach, if we don't work from a proper, comprehensive, integrated strategy to tackling this problem, just as those who are making money out of vaccine critical misinformation are doing, then there is no way we're going to successfully combat this challenge. Just to organize our thinking, I'm moving now to solutions, and just to organize our thinking, we at UNICEF and within the Vaccine Demand Observatory that I'll present in a second, organize our approach to the impact of COVID-19 on immunization programs through three key themes. First is tracking and assessing misinformation in near real time, understanding how to address that. Secondly is understanding potential hesitancy and hopefully demand for new vaccines, including any SARS-CoV-2 vaccines, but also the new OPV vaccine coming through. And the third one is using social listening approaches to help us understand and potentially mitigate the impact of COVID-19 on the provision of, the access to, and also demand for immunization services. It's important when we start to build a strategy that we understand the key questions that we want to address, that we want to ask. Now I'm going to flip to solutions, and I want to spend 3 minutes talking to you about the Vaccine Demand Observatory, which is an initiative that UNICEF has kicked off with 3 partners, but that UNICEF is already starting to coordinate through the Vaccination Demand Hub with other agencies, other multilaterals, the Demand Hub specifically with WHO, Gavi, CDC, and BMGF, but with other partners within there, including our partner Sabin today. Goods Project, which is a US not-for-profit that is taking the lead in particular on developing a customizable social listening and analytics platform with dashboards that can be taken into countries and customized to countries' needs. We're working with First Draft on social listening, but also on developing the first steps towards a learning academy to help develop infodemic managers. Those of you who've been following the infodemic conferences that the WHO has held, the infodemiology conferences that the WHO has held have seen that one of the conclusions was that we need infodemic managers. I'll come back to this in a second. And also the Digital Interventions and Assessment Lab, in particular with Yale Institute for Global Health, a center of expertise in the behavioral science of vaccine decision-making. We want to start designing and rapid testing messages. But what is really important about this initiative is that this is not some global initiative that is going to do global social listening and develop global messages. We are working to develop the tools, the technical support, the resources, etc., that a country would need to implement their own social listening and engagement strategy. Now, as I explain a few of these pieces of the Demand Observatory, I'd be very interested to hear if you have any thoughts about what you would like to get, what support you would need, content, tools, training, etc., that would help you in your work tackling disinformation. Please use the chat feature. The first deliverable that I mentioned is a cloud-based platform that will enable a country to funnel different data sources, traditional media, which is mostly digital, or we can get a lot of it digital, all the online media, not just the classic platforms, but blogs, search functions, chatbots, YouReport, etc. But we also want to see how we can plug in real-world data, analog data if necessary. The idea being that when you can get all of that data into a single data lake, you can really make sense of it now through the powerful algorithms that we can develop that can help us really tease the signals out of the noise. We'll be working on developing algorithms specifically for vaccination-related concerns, questions, conversations, algorithms that we hope will detect not just sentiment, but intentionalities, for example. And that idea is to make it as easy as possible through a visualization in dashboards for that infodemic manager to start to make sense of it, to start to consolidate it into insights, recommendations, intelligence that they're then able to feed to those in the field, those doing their risk communication, community engagement, communications, advocacy, etc. That infodemic manager, one of my colleagues at CDC, Liz Wilhelm, calls a unicorn, and that's stuck. I think we're all going to be wearing unicorn t-shirts soon. We're coordinating closely. We're hoping to make the first step towards putting some training out there for these unicorns, but we imagine that this will really, that training will really become a joint effort down the track. Secondly, we want countries to have a proper operational framework, a full strategy that covers all of the steps that are necessary to couple effective social listening with rumor assessment, development of actionable insights to the actions in the field, and to outcome tracking. We're tentatively calling this the mascot method. There's a step of preparation, information ecosystem analysis, understanding where the conversations are, who's in them, what channels are they on, what's being said, building the system, then setting up the monitoring, as I touched upon, assessing information, the misinformation, finding the gaps, understanding, deciding whether or not to address misinformation, because as you've seen, addressing it can potentially backfire, developing situational insights, and then feeding all of that into the activities in the field and having really good outcome tracking. And so the idea is that this framework would really be the backbone of that integrated misinformation management strategy. Let me just say here at the end, I will be announcing, but we are close to publishing a vaccine misinformation management guide, which will have all of this content with a lot more detail, solidly referenced throughout, available, we hope, in the very near future, and we'll make sure that everybody's made aware of that when it becomes available. With the Yale Institute for Global Health, but also with the partners PGP and First Draft, we're looking at how we can develop a workflow that would allow us to understand the issues, the general misinformation, the specific narratives, draft and design messages, and I'll come to this in a minute. We can actually inoculate people against misinformation, rapid A/B test it, customize the content for the channels where it's going to be, really understanding what it is people are looking at, what they're viewing, and then getting that out there. So now I'm going to spend the That's been 25. I'm going to spend another 3 minutes on what we can do, and then I'm going to be quiet. So I want to look at three key pillars. We can essentially inoculate people. This is an emerging science against misinformation in general and specific disinformation narratives. We can get out there and set the agenda, and we can do things to control the spread of misinformation. This is an algorithm that I won't go into today, but as I touched upon, we need to be able to decide whether or not we're going to address misinformation. First of all, we can inoculate people against misinformation in general. This is called pre-bunking. I will draw your attention to the Debunking Handbook 2020 in a minute, which contains a background, a really good idea, explanation of the difference between pre-bunking and debunking. We have an online course from our partners, First Draft, that any of you can take tomorrow, that you can share with your families to start to build a level of baseline immunity against misinformation. A game that was just released a couple of weeks ago from Cambridge University, from the UK Cabinet Office and other partners, that is based on another game that's been shown to effectively inoculate people against misinformation. We have a randomized trial of a curriculum for primary school students that was performed in, I think, over 120 sites in Uganda that showed a very clear and significant effect on primary school students' ability to think more critically about health claims and make informed health decisions. And it's also available for adults. There is a methodology for debunking. I've run a little bit too far, so I'm not going to go into it today, but this is in the Debunking Handbook there. I'll share this on Twitter afterwards. You lead with the fact, you make sure it's clear, resonant, and sticky. You provide a misinformation alert. You can give the misinformation in a weakened form, but only once, because as we saw, familiarity breeds truth. You alert people that there are misleading tactics coming up. Then you point out the way that people are being deliberately deceived, either by highlighting the misleading tactics that are being used. There's a whole fantastic taxonomy developed by John Cook, Steve Lewandowski and colleagues that you can look at. Or, and I think this is important for vaccination, by highlighting the underlying agenda, the hidden agenda that people have, the hidden motives that people have for developing and disseminating that disinformation, which in general is either to monetize, to politicize, or to polarize. And then you provide the fact again, because you need to fill the gap that you've created by removing the myth. I'm going to have to move quickly now. We need to get out there and set the agenda. We need to be developing content that is resonant, that meets people's needs. It should be cataloged. It should be placed in content hubs at country level, at regional level. It needs to be accessible and sticky. We need to amplify the voices out there that are trusted, and we need to galvanize new trusted voices, healthcare workers, youth, religious leaders, etc. We need more voices in the conversation, more trustworthy voices. We can empower journalists. There are reporters toolkits out there that empower help journalists to identify and understand misinformation. Fact checking is fundamental. We can provide reference experts for those journalists, so it's easy for them to get the access to the science of the issue that they're addressing. We can push social media platforms and support them to control the spread of disinformation at a structural level, to redirect people to when there are searches for vaccines, to reduce the visibility of disinformation, misinformation, to demonetize it, to even deplatform those accounts that are making a lot of money out of it and having a real impact. We can limit the spread through limiting message forwarding, etc. There are different things that can be done. Let's, for example, we had new policies from Facebook announced just recently. Let's hope that those policies will start to have this impact on the spread of disinformation, of vaccine disinformation. So I'm going to stop now. I'm going to leave you with three thoughts. I would have loved to get into the inoculation in a bit more depth, but I had to set the scene. You have that debunking handbook that will tell you that we can inoculate people, show you how we can inoculate people against misinformation, and that what I want to leave you with is that we should also be thinking in long term, how do we build innate immunity in communities, starting at school level against misinformation through some of the strategies that I've shown you. Strategy is my first point. This will not work if the approach is ad hoc reactive responses, which often, almost always, are not sufficient and may actually backfire. And lastly, and this is the most important point, if you remember only one thing from my presentation today, our job through social listening is to be able to listen through that fog of disinformation, to hear the questions and concerns that people have about routine immunization, about new vaccines coming up, and to respond to those questions through trusted voices in a way that will make people feel heard, that will reassure people and make them feel heard. That is more important than inoculating people against specific disinformation rumors. Change starts at home. I mentioned that public online guide. You can all take that tomorrow from First Draft, and the Misinformation Management Field Guide is coming very soon. And if you stay tuned to this series of webinars, we'll let you know soon when that is available. Thank you all very much.
Thank you so much, Angus, for that presentation. Just a polite reminder, if you have questions, kindly use the Q&A box, and then the chat box will be used for other things like the ones we were discussing during the presentation. So we are launching another poll question, the second one. So it's we have 30 seconds to respond to the poll question. And the question is, in your work, have you implemented any strategies to manage vaccine misinformation? In your work, have you implemented any strategies to manage vaccine misinformation?
And Lucy, while people are answering that poll, we're going to tell everybody about the other two webinars in this series, but the third webinar will be with Steve Lewandowski from the University of Bristol, one of the authors of the Debunking Handbook version 1 and version 2. And so we'll be able to dive into those practices of inoculation, of pre-bunking and debunking in that webinar.
Thank you. So we have 30 seconds to respond to this poll question. So let me see what we have here. So in your work, have you implemented any strategies to manage vaccine misinformation? Remember, there's no right or wrong question. So 14% of us say that, yes, we've implemented an effective strategy. And then 42% of us say yes, but there are still issues with vaccine misinformation. And then 18% of us say not yet, but we have a strategy planned. So 26% of us say no, where do I start? Don't worry, we are all in the right place, and we'll be able to have our answers at the end of the presentations. Thank you. So we'll move on to the next presentation. Jonathan is now going to share Pakistan's risk communication and community engagement strategy to promote behavior to reduce risk and limit transmission of COVID-19. Jonathan, take it away.
Yes, thank you. Thank you very much. And hi, colleagues and participants. First of all, thanks, Angus, for, like you said, setting the scene. I think very, very well done. I think everything I will be presenting really falls within your presentation. But first, I would like to just take a second to well, the presentation that I'm going to be is brief. It's only 5 slides, but it's really to bring in the perspective from COVID-19 here in Pakistan. And the focus is really on the use of social data. Please go back to the first slide. Please back to the, I'm still on the first slide. Yeah, thank you. And yes, just really focusing on the strategically on the social data and the evidence to correct misinformation and make strategic shifts in RCC interventions. First, I would like to, though, acknowledge that I'm really speaking on behalf of Pakistan office because when I arrived here 6 weeks ago and inherited all this good work that I'm going to be presenting from my predecessor, Deepa Pukarel, and her great team here in Islamabad. But what I found was a really impressive investment in resources to to provide platforms for social research and related misinformation, attitudes, and behaviors. And I see that it really, really paid off. And the mysteries of this misinformation are often heard, experienced, but rarely explained. And this is what we went out to set out. Next slide. Yeah, thanks. And here, as a general overview, we note that the strategic pillars of the Pakistan risk risk communication and community engagement response. In bold, we see the use of the social data, the quality of research, and actively responding to resistance and misinformation remains a central part of the COVID-19 response strategy in Pakistan. And I also want to just maybe really quickly add here that the perspective of misinformation takes into account the larger context of misinformation. I think, like Angus was also saying, which is ever changing and should not be addressed in a vacuum, because when different events change, so does the information and so does the misinformation around it. For example, you know, at a global stage when COVID was politicized, we also saw a lot of misinformation that also reflected the different political views. So when analyzing misinformation, the overall context and motives is also important to understand. Next. Here in this slide, the idea is to mostly show how intentionally and the intentionality and purpose of using social evidence to guide and orient communication strategies and approaches. On the left side here, we see that we collected from 15 sources, both locally and globally, including social listening, anthropological studies that we're doing on the field, and also a team to conduct longitudinal surveys to show the evolution and shifts over time. With all this information that was collected, it was actually, we started on a weekly basis. Now it's every 2 weeks. We then recruited an expert to do the heavy work and produce the RCCE briefs, which is in the middle. It's a document that collects all the information, analyzes it with a team, and puts the most relevant highlights in recommendations. And from these briefs, as we see on the right, they go out to recommendations to 3 different areas: strategic action, which is for policymakers, and the central coordination committees; sector response, which is for all the pillars from the response; and then the communication interventions and what further research is needed. And from these recommendations, we also have an action an accountability matrix on who is acting on these recommendations and who is responsible for them. So from these briefs, let me just show you 2 examples of these. Next slide. From this slide, one of the first things from the social analysis, from the social listening, we see that 69% of respondents think that they will remain protected if they do their prayers 5 times a day. So this is in Pakistan. And we were very worried and concerned because there were, throughout the year, from the beginning of the pandemic, there were 3 or 4 major religious events and ceremonies taking place. And there was concern, and the analysis was showing that most religious events, most people and most religious leaders were planning on going through with all these ceremonies and all the big crowds without wearing masks, without social distancing, and without respecting some of the preventive behaviors. And from that, the recommendations were to address this in a very aggressive way, and the actions were dedicated coordinations of partners, extensive media campaigns, the ring-back tones, decentralized interventions, engagement of imams and mosques. We engage the tourism police here in Pakistan, and other awareness and markets, and the community-based committees which were also activated. So this did make a very big difference. People were aware of this in a way that was very different from before we had um, the analysis. Next slide. Um, and in this slide, we see that here, I mean, just another explanation of how we dealt with some misinformation here in Pakistan. In the early stages, health workers um, then health professionals were increasingly infected with COVID-19. And the social listening was saying that the population was blaming the health workers that they are the source of transmission in the community. You know, they were the first ones to take care and treat patients, and so them getting infected and them going to other homes also infected other people. So the result was people were not going to clinics, and all health workers were being stigmatized. And because we had that information, recommendations came out to initiate a campaign that's called We Care. And the idea was to promote their dedication and heroism towards this. Um, and the campaign went on for about 2 months, and that included videos on national TV and video and radio, social media, mass media, yeah, trust building groups, religious leaders. So that was very important to move forward. To add, the limited distrust of healthcare workers was initially due to the fact that they lack training on how to better protect themselves. So in a way, much of the misinformation really was a consequence of the system. And yes, I could say, let's say, our fault, and could have been prevented. And this is why teams from both demand and supply side should be working hand in hand much more. The inclusion of the RCCE modules in all trainings is a must. So when we are training health workers, there should be a module for how to address misinformation. This is very important, and our studies have shown they have not been included. Next. And here on my last slide, just some lessons learned from here. The first is consistent social data analytics and social listening is a powerful tool to inform program, influence decision, and understand what Angus said, the stickiness of misinformation. Yes, misinformation has a stickiness factor to it, and information itself is rarely the factor, but rather how sticky the belief is to people in their context. That gives it the credibility. The second point is media and social media can create a favorable environment for change. However, change itself is most sustainable through interpersonal and participatory approaches. 64% say their final decision was most influenced by peers and not experts. So that peer-to-peer, that one-to-one, those testimonies are just as important as highlighting experts, even more important. On the third point, 61% do not have strong convictions. They are simply uncertain and waiting to see how things turn out. They are thinking it's better safe than sorry. Thus is what Angus was talking about, the hesitancy part. And since there seems to be controversy over wearing masks, I mean, here in Pakistan, most are decided, well, I will see how things turn out. I will see if my peers are wearing it. But for now, I will wait to see what happens. And on the fourth point, also use peer-to-peer influence to combat misinformation and not only expert-driven. 77% trust the opinions of their peers. And last, immunize health workers against rumors, as very few are trained on how to counter misinformation. 57% of health workers say patients inquire about the truth of rumors that they heard. So again, I repeat, it's very important to include some training modules for health workers on how to treat misinformation, how to identify misinformation, and how to debunk some of most of it. Thank you.
Thank you, Jonathan, for the presentation. A polite reminder, keep the questions coming, and we're going to answer them at the end. So Aisha is next. She's going to speak to the use of social data from digital media analysis, digital campaigns, and advocacy to address misinformation around immunization in Pakistan. Aisha, take it away.
Hi, everyone. So I thought, let me start with a photograph of our communities. So these are the children, the caregivers, and our frontline workforce from Pakistan. These are the people that we are speaking about. So misinformation generally starts from a lack of knowledge. When people don't have access to accurate information, they tend to use, like Angus spoke about it, they tend to use reliable sources of information rather than confirming whether the information shared on them is accurate or not. So moving on from what John has also explained about how we handled misinformation through social listening, behavioral data in Pakistan, I will take you to the next slide, which will give you an example of the social media or digital media sentiment analysis that we run on a weekly basis. We've been doing it for COVID as well, but today I'm going to speak about the sentiment analysis that we do for routine immunization and the polio program. So we look at public's perception, both negative and positive. And the forums that we actually monitor are on the left corner at the bottom. So these are the digital forums that we monitor. So it's a mixture of manual tracking as well as use of keyhole software. So we try to identify what is the public saying, what is the conversation in each province around immunization. And then we try to ensure that the negative sentiment doesn't really go very high. But during COVID, a lot of activities came to a standstill and the public was generally complaining that services were not available. So the negative sentiment was a bit on the high side. So there were public's concerns about how to protect themselves while coming in for vaccination. So a lot of misinformation around that as well. And then there were also rumors or misinformation that the doctors could not differentiate between the typhoid cases or COVID. So different public sentiment that usually comes up, and we manage, when it's tracked on a weekly basis, we can fast track it to the concerned officials to ensure that immediate action is actually taken for each task. If you look at the circle which says gender, so for whenever we do the digital media sentiment analysis, we find out that women tend to participate less in public forums. But for immunization, because as they're the primary caregivers, they are our target, one of our core target audiences. So females are present on at least 22% of them are present on public forums. So you need to engage with them in closed groups and other areas. This is just to give you a snapshot of what kind of information comes in. So a lot of misinformation usually comes in and it's easier to track it. Next. So this is to, I know it's a very busy slide, but I actually wanted to link up the TCV campaign, the typhoid conjugate vaccine introduction in Sindh in 2019, and a crisis which happened on the first day of the campaign because of misinformation. So there was a negative post about an adverse event following immunization in Orangi town, where actually the AEFI didn't happen. It's just that like the students fainted due to fear of the vaccine. Children under 5 years cry, but they get vaccinated. They don't faint. Whereas older children, we found to our regret, that they tend to faint, they create a panic. And this is what happened in a school in Orangi town. It was one of the polio refusal schools. And as we did not have access to that information on that day, what happened was that the post went viral. The video was made of the whole incident, and it was posted on an NGO's Facebook page, and it was also picked up by the media. A video statement, a very strong video statement, was also made by the chairman of the All Private Schools Management and in Sindh, which created a lot of negativity. So the negative sentiment on the first day of the campaign went up to 11%. And what we did was that we immediately got in touch with the Facebook team through our polio communications team. And a lot of the negative content was taken off, but some of it, we reached out to the JDC Foundation. We also reached out to the chairman of the All Private Schools Management Association to ensure that they retracted the statement. After an investigation team actually went to the Orangi town, investigated the matter, and found out that nothing serious had happened, because it was the first day of the campaign and it would have completely derailed it. Another thing which we did was that the commissioner of Karachi, actually, his video statement was recorded overnight, and it was shared through all the social media networks over the media. We did different activities, and we engaged a lot of bloggers, influencers, media houses to post a lot of positive content. That's one way of dealing with misinformation, because you don't always start the retractions only. You don't just issue a press statement. You first start with the positive content. You try to divert the public towards what is correct. So you get pediatrician, other trusted sources of information to verify what actually happened and what needs to be done. So the whole incident, we were able to bring the negative sentiment down to 4% within a few hours through a multitude of activities. So on the left side, what I've highlighted is that we had refusals from a lot of schools after the incident. And we had prepared for any eventuality. And we had board games, we had a video game on typhoid, and then we also had an activity book. These were immediately launched into all the refusal schools so that we could engage with the children, convince them that the typhoid vaccine was actually for their own safety. We also had a chat bot developed for Facebook and for the Federal EPI's official Facebook page. And we answered a lot of public queries coming in from that. So we tried to ensure that whatever the public's concerns, we were addressing them as soon as possible, like within an hour, I would say, rather than delaying it. So we tried to engage the public through Facebook, WhatsApp, Twitter. Most of our frontline workforce can be accessed through WhatsApp. And we usually post positive content through WhatsApp so that they can also share it with their wider groups. We were able to increase women followers after the campaign up to 52%, which is pretty high, because it's very difficult to engage women in Pakistan on these forums. So overall, our social media reach was around 10.3 million, and this is just for Sindh. And our hashtag was Mission Typhoid. So in these priority areas where we were facing refusals because of the misinformation, we also targeted 2.4 million robocalls and 15 million SMSs, which were made in the voices of key influencers from those communities. We did them in the local languages. So it was done in Urdu, Sindhi, and Pashto to ensure that people heard what was actually true. Next, please. In addition to those other activities, so we were facing refusals from religious groups, the media was criticizing, and then we were also facing refusals from schools. And what we did was we held different activities with the schools. And so our influencers went in, teams went in to engage with the different schools to convince them. And then we also did advocacy with religious groups to ensure that all the children in madrasas were also getting vaccinated. Then an event was organized at the Karachi Press Club. And in that, different media personnel and their children were vaccinated. So they posted a lot of positive content after that. So all in all, multiple activities were done, multiple partners were engaged, pediatricians were engaged. And the success of handling misinformation is basically all partners need to come together during a crisis, and they need to work very closely with the government. So it's not dependent on one individual or one organization to change the landscape. It's everyone coming together to do that. Now, moving on to the next slide. Looking at our experience in the measles campaign in 2018, then our TCV campaign in Sindh in 2019, under our global partnership with the Facebook team, Pakistan was one of the countries where we are working under this partnership. And Facebook provided very good insights to us using their social media listening tools. And in that, they provided us anti and pro-vaccination topics, which are popular according to the public. So on the left side, you see all the anti-vaccination topics. These feed into misinformation. And then the ones on the right side, which are in shades of blue and green, are the ones which promote vaccination. So you have to use both. You have to address the anti-vaccination topics through the support of the pro-vaccination topics. So the influencers who are posting pro-vaccination topics or messaging, you need to engage with them to counteract all the myths, information that are going around within the community. These are actually, people listen to them. So they form opinions, public opinion. And we found to our cost during the measles campaign that if you do not invest as much in your social media campaigns, the tactical planning and the crisis communication management for your social media work, your other work your other activities tend to suffer because you need that linkage between the two. So I won't go over each of these topics, but these lead to misinformation, at least in Pakistan. Next. So based on these insights, the social media or digital media sentiment analysis that we run and the insights that Facebook provided us, we were able to determine that 80% of our adult Facebook population is actually under 35 years of age. So the content that we were developing was not really tailored towards their need. And we had to activate a younger audience to ensure that our messages were actually being accepted and were liked. And people were taking notice of them. And then women tend to talk more about vaccines compared to men because they're the primary caregivers. So we need to engage with women more. Men tend to talk about the political aspect of vaccination, whereas women are more concerned about their child's health. And they are actually hungry for information. And then we need to do proactive counter messaging. That's one of the only ways that you can handle misinformation. Otherwise, it gets out of control. And then awareness days or other key events can be very effective in leveraging leveraging this information. Like they can be leveraged to share this information. and to engage with the media, with the public, to ensure that our message gets across. And Facebook, as part of this support, is also helping us do a brand lift study. So they are providing us ad credits to boost some of our content, and also doing the brand lift study where we can look at the different content divided amongst different age groups and see how well the uptake is, so that we can improve our future campaigns. Next. No, the previous one. So our EPI, based on all these insights and with our partnership with Facebook, we recently launched a digital media campaign from federally expanded program on immunization's official Facebook page or official social media platforms. And we were able to reach our target. Our target was actually to have a total reach of around 6 million for the EPI Facebook page, and we were able to achieve that. Broadly, through other social media platforms, we were able to have a total reach of around 14 million people, and it's still increasing every day. We had extensive additional reach done, supported by the Pro Pakistani, NetMag, Zong, which is a telecom company, and US Embassy in Islamabad. We also had partner support from the polio program. UNICEF Pakistan's external communication team helped us in boosting the content, as well as Ministry of National Health Services Regulation and Coordination. So everyone worked together. This way, a lot of traffic was actually moved towards the federal EPI social media platforms. So instead of everyone posting content on their own, we requested them to reshare, repost from the official platform. So we didn't boost the UNICEF page. We actually boosted the government's official platforms because it's, according to one of the insights provided by Facebook, page affinity for the EPI page is very high. People trust it as a key source of information on immunization. So that is because all their questions are answered on time. They have access to information, accurate information in a timely manner. That it counts a lot. Next. So overall, through this campaign, we have given you an insight on our following by age and gender. If you look at it, most of our, the highest number of audience for us is between the ages of 25 to 34 years. 26% of it is women, and 31% is men. And we targeted youth through specific content, like we developed quizzes, we developed crossword puzzles, and other interactive GIFs and other interactive content that the youth generally engaged with. Very, very short videos, very short information, so that they get their daily dose of information. And also through ad boosting, ad credits by the Facebook team, we were able to reach our intended youth group. The campaign sentiment, overall campaign sentiment, has stayed on the positive side at 42%. So neutral sentiment is also at 53%. We have been able to maintain the negative sentiment at 5%, which is very good, that people were actually hungry for information. So we didn't face a lot of misinformation. There were bits and pieces here and there, comments, but our bloggers and influencers immediately engaged with them and started posting positive content. So it was nipped in the bud immediately. And we have been able to engage 61% of our female audience in that. And we have been able to increase the page engagement for EPI's official Facebook page. Next. So these are just, this is my final slide. And this is just some of the short message cards that we've developed on misinformation, because and all this information is actually based on what the public is demanding for. So they asked questions around that. They had issues about the vaccines, where are they manufactured? Are they safe? Are they effective? Then are they part of the EPI schedule? And then misinformation around vaccines. So we try to address it in as many ways as we could. So whenever any kind of question pops up from the public, we have our material ready. So we've tried to make it as interactive as possible. I'm happy to answer any questions that you will have in the chat box. This is it from me. Thanks.
Thank you, Aisha. So before we open it up for the Q&A, we want to hear from you. So this is the question. Can you share how, it's not a question really, it's an experience. Can you share how you've addressed vaccine misinformation where you work? So kindly use the raise hand button. We'll only have 2 people, and because of time, keep your answers short. So I've seen AK Kamruzana Zaman. Your hand was up. I don't know whether it was a mistake. So we have Justin Halley, I hope I pronounced your name correctly. Kindly go ahead, unmute yourself and share. And then we'll have Samuel Tezera.
Thank you, Lucy.
Unfortunately, we only have time for those 2, but kindly chat in your experiences as well. We'll be happy to read them. Thank you.
Thank you. Great presentation. In terms of addressing vaccine misinformation in the UK, we've been very careful to be careful not to rebut directly the misinformation and especially the disinformation, but instead to support and ramp up and increase our messaging around the safety of the programme, around the benefits of the programme, and to be very transparent about the information around the programme so that we support the healthcare workers to have those conversations. We often do a type of FAQ or a short statement to address any concerns, and we have a constant meeting with our network of leaders in terms of screening and immunization, and there we can get cold-face feedback of what rumours are causing problems and directly provide solutions within real time so that they can send them out to their networks. But it's very much working across multi-channels and supporting them sort of nationally with main messaging, but much more targeted messaging regionally. Thank you.
Thank you. So we had Adefunke Adesina. Your hand was up at one point.
Thank you so much. It's a wonderful presentation and experience sharing. I would like to ask that how will you address the misinformation to vaccine, especially those ones that happen in this pandemic? Thank you.
Maybe Adefunke, you could share. Can you share how you've addressed vaccine misinformation where you work?
Yes.
If you could kindly share one experience, if you have one. Thank you.
It's like I work in Lagos State Ministry of Health. I'm the monitoring and evaluation focal person. Concerning the misinformation, the myth of vaccination, because when especially in this pandemic, the people, initially we used to have something around oral polio that it could cause infertility in some children. And the intention of using this around the world is to reduce the population, especially in the low, among the less privileged, less educated set of people. When the COVID now came again, it seems as if it was even some of these vaccine they've been taking brought the immunization. But what we do kindly is to, to re-immunize our health workers firstly, to let them know that in kinds of giving them the adequate information, and to re-emphasize in few sentence what this immunization does. And we try to call our stakeholders, the community people, especially those people that we call World Health Committee, and to again remind them of what immunization is. And we try to send these people back into their community to help us to re-emphasize on what immunization does. And we clarify basically the difference between COVID infection and other children preventable vaccine, those antigen preventable diseases that we have on ground. And later, people tend to understand that this COVID is a new thing. It wasn't even has any relation with the other vaccines that we have already on ground. And there's this particular thing that came at some point about the BCG vaccine and the COVID. Also, what we did again is that we resensitize our community, especially the stakeholders, the religious people, the religious leaders, who actually help us to talk one-on-one into their friends, their relations, their families, and to let them know what exactly all those vaccines that we have on ground does, those antigen. And by and large, we try to, thank you.
Kindly summarize, just finish up 1 minute. Okay. So yeah. Kindly submit your experience in the chat box. Unfortunately, we don't have time. So we'll proceed to the questions, and some of the questions will be answered in the chat in the Q&A section, because in the interest of time. So allow me to ask Engas, if you're there. So I'll ask you 3 questions. What is an academic definition of infodemic? And then how do you tackle misinformation in media dark areas? So
yep. Hi.
Engas, if you can hear me.
I'm looking up the definition. the point I think of WHO coining this word infodemic, and the infodemiology conferences that have been heard, and now the training for infodemic managers, is really to focus everybody's attention on the need for a kind of a cross-disciplinary field, which, as you saw from my presentation today, touches many different disciplines in the cognitive social sciences, public health, communications, etc., to try to start to catalyze a new, maybe field. It's not really a discipline, but a field that would then allow us to, as we've already done in the 2 conferences, bring together expertise from different contexts, but also apply that kind of mix of expertise to finding solutions on the ground. So infodemic is simply the correlate of pandemic. Pandemic is a global spread of a virus. Infodemic is global spread of information, misinformation, and disinformation. But maybe someone, Liz, can share the exact definition on the Q&A. I was looking up something else while you asked this. And
okay.
Media dark areas is a big question. So we can access certain social media channels through some of the current social listening tools and media. We, UNICEF and partners have outreach into communities that allow us to do community listening and get feedback from that. There are dark areas out there. They're hard to monitor, and obviously they're hard to respond within. But in a lot of kind of closed, well-hidden groups, the circulation of disinformation is not necessarily a major concern. It's only when it breaks out of that, or if the disinformation is actually being designed within those groups and then released into the public domain. But there are many questions in this field that we still have to answer.
Thank you so much. So allow me to ask the final question, but don't worry, if we haven't answered your question, we're going to answer it. So I had seen a question, just a minute. So someone is asking, so Hini actually was asking Jonathan. I think the questions have been answered. So we have open 4 questions. So in many countries, men refusing their spouse to vaccinate children. Some of these women have to do it without their spouse knowing, but many are not taking the risk to do that. So can you share any strategy to reach and focus? Can you share any strategy that men can be reached with the information in relation to that? So he's asking about men not being supportive, some men actually not being supportive of the vaccination. So in case we can share any strategy about that, because some women are not risking taking their children. So I don't know, Aisha or Jonathan, if you could kindly answer that.
Sure. Jonathan, would you like to, or shall I?
No, please go ahead. Go ahead. There's a lot of polio people on this on the panel too, on the as participants. Go ahead, Aisha.
Okay, so what we've learned through the polio program and routine immunization is that these men, you need to engage with them through the key influencers within that community. Sometimes you don't reach out to them directly. So these key influencers are sometimes leading the misinformation. So you need to address it at the different layers. You need to answer their concerns, their fears, reassure them about the benefits, effectiveness, and then try to get their concurrence on getting their children vaccinated. It's not a very short process. It can be a long, drawn-out process as well. Continued discussions back and forth, but at the end of it, it's actually worth it. For us, it's the religious leaders, the local community elders. It can also be the local doctors, pediatricians, and sometimes even celebrities who shape public opinion. Sometimes in our case, like for COVID, we noticed that if our prime minister said something, public generally tend to listen to him. So you have to find the right influencer to convince the public. I hope I was able to answer, because it can be the other way around as well. In Balochistan, we heard that it was men refusing the vaccine for the measles campaign, but it was actually the women who were guiding the men that they didn't want their child to be vaccinated. So you have to delve deep into it. You need to find out what is the actual issue.
Thank you, Aisha. So I think we'll close the Q&A section now, but don't worry, we'll make sure that we respond to all the questions. So this is a reminder that the webinar we had today is part 1 of our 3-part webinar series, a partnership with Sabin and UNICEF. We will follow up with attendees with an email where they can register for the second webinar and follow the 3rd webinar. So at this juncture, allow me to hand it over to Caitlin Christensen, Sabin's Vice President for the Vaccine Acceptance and Demand Program. Caitlin, take it away.
Thank you, Lucy, and thanks so much to our panelists for such an excellent discussion and presentation today. Good morning, good afternoon, good evening to everyone. We really hope that you enjoyed today's webinar. So if we go to the next slide, please, just a reminder that if you are interested in following up with Sabin's work, you can keep up with our vaccine acceptance and demand program, either through our website by following us on social media, or you can reach out to us directly at info@sabin.org. As Lucy has said, we will follow up with all attendees after the webinar today to share resources, presentations, webinar recording, and key takeaways from this webinar. Next slide, please. Another opportunity to engage with us and continue the conversation is by joining the Boost community for immunization professionals. If we can go to the next slide, please. You'll see a link to where you can log on. And again, we'll share this information with you following the webinar today. On the Boost community, you can engage with peers and connect with others, as well as find additional resources that will support your work. And then next slide, please. There are a few opportunities through which you can continue the conversation from today and engage with peers through the Boost platform. We also hope that you'll take a survey that we'll share with you following today's webinar, and be on the lookout, as I said, for a summary of resources from all of us. So with that, I think we can conclude for today. Again, just want to give a thank you to our excellent panelists and our wonderful moderator, Lucy, and particularly to all of you for joining us today. Wishing you a pleasant rest of your day or evening. Thank you.